I'll just start the recording now, and then yeah, over to you, Michelle. Thank you.
Oh, no problem. So apologies, I'm stepping in at the last minute. I have tried to prepare as much as possible, and Kirsty had very nicely put together a little presentation with some slides. So she's shared that with me. So I will share my screen and go through those slides with you, and hopefully just open it up a little bit as well, so a bit of discussion or any questions or queries that you might be having in terms of obs and gynae. Just to introduce myself properly, I'm Michelle Sheridan, so I'm one of the obs and gynae nurses, and then my other colleague who would have been doing the session today is Kirsty Redmond Fisher. So there's just the two of us at the moment, but we are due to be getting a new obs and gynae nurse joining our team, which is very exciting. And she's called Annette Orton. So there will then be the three of us that you can get the support from. So let's hope that this works. I'm going to share my screen. I'm not always the best at this, but let's give it a go. And then can everybody see? Yeah, can everybody see it? Perfect. So please feel free to stop me at any stage, because I don't just want to like talk on at you. But I'll just go through some of these slides that, as I say, Kirsty very nicely put together. It's just a little bit of a brief overview into some of the common gynecology things that you're probably authorising every day, but just to give a bit of an insight. And then the last few slides, she's just put a little bit of information together with a little bit more sort of information about what myself and Kirsty do and sort of how you can liaise with us, if that sounds okay. As I say, you're probably authorising a lot of these procedures sort of day in, day out, because they are quite common gynecological investigations. So first and foremost, one of the most common investigations that we get out there in gynae is what we call a hysteroscopy. So under Bupa, that's the Q1800. So I'm sure you've probably authorised an awful lot of these. So a hysteroscopy is where they have a little scope with a camera on the end that they just gently pop through the vagina and the cervix to then give them a view of the uterus. And that little camera then transmits those images onto a screen that they can then look at, so they can have a good look inside the uterus. Primarily used to investigate symptoms. Most commonly, the symptoms would be abnormal bleeding, so either heavy bleeding, bleeding in between periods, bleeding after menopause, bleeding after intercourse, all those sorts of abnormal bleeding, just so that they can see if there is anything within the uterus that might be causing that bleeding, or to give them sort of a diagnosis. It is usually just a day case procedure undertaken in outpatients. Some ladies will have them done in theatre under general anaesthetic if they're not able to tolerate the procedure in outpatients, but otherwise it can just be done like under a local anaesthetic or a sedation in the outpatient clinic. So usually a fairly quick procedure, and then coding wise, it's usually the Q1800 when they're for diagnostic purposes, and then we do have the Q1700 code, and that's usually when they need to do a little bit more treatment. So Q1700 covers things like an ablation, which is the endometrial ablation, just to remove some of the lining of the uterus, which often then helps to relieve heavy bleeding or abnormal bleeding. Commonly as well, with hysteroscopy, they might remove what we call polyps, which are just like little harmless growths that can grow within the lining of the uterus, but they can cause abnormal bleedings. They can often remove those as well at hysteroscopy. So that's those in a little bit of a nutshell. Then we've got your laparoscopies. These are where they make very small incisions in the abdomen. You may often hear it sort of being termed keyhole. It's just a minimally invasive either investigation or surgery. So again, they can both diagnose and treat conditions. Laparoscopies are generally performed under general anaesthetic. They're not usually performed without a GA. But again, predominantly usually a day case. They don't usually need to be admitted overnight. So as I say, they will make one or more small incisions, keyhole incisions on the abdomen, where they can then pass the laparoscope, which again is just a little camera, and other small surgical tools if they need to do any treatments. So roughly takes between 30 and 60 minutes. And with keyhole surgery, they do normally have a short hospital stay, quicker recovery time, and less sort of side effects afterwards, as opposed to like any open surgical procedures. Just a quick note on laparoscopies again. So usually you will see like a laparoscopy as like an additional investigation. So say, for example, if they're looking to try and diagnose the condition of endometriosis, that's how endometriosis is usually commonly diagnosed at laparoscopy, because it just enables them to have a much better view of the uterus and the surrounding pelvic areas. So these are your codes, like the Q3 900 is like an investigative laparoscopy. And then you've got like the Q3 800, which is more a therapeutic laparoscopy, which includes some treatments where they might just remove like some scar tissue or adhesions or treat some like minor endometriosis at laparoscopy. So those are the couple of codes there, which again, I'm sure you authorize fairly frequently. Um, she's then just popped on a little bit about hysterectomies, which again are fairly common that we authorise here at Bupa. They can either be done keyholes or laparoscopically through the vagina or abdominally. So there's varying different hysterectomy procedure codes here at Bupa, but like your common ones for your laparoscopic are the Q0790. For your abdominal, your Q0740. We don't authorise very many vaginal ones. It tends to be more the laparoscopic and the abdominal ones. Again, varying reasons why they might need to go on and have a hysterectomy, but what we would usually expect before they get to the hysterectomy stage is that they would have explored lots of other avenues of treatment first before they'd get to the point of hysterectomy. But generally speaking, they're used to relieve or cure a range of gynecology conditions, including heavy bleeding, so heavy periods, long-term pelvic pain, and then those conditions of fibroids, endometriosis or adenomyosis. Sometimes used in conjunction if there's a prolapse as well. So if the uterus has prolapsed, if the cervix has prolapsed into the vagina, they will often perform a hysterectomy as well alongside treating the prolapse. And then obviously for cancer purposes as well. At the minute, our hysterectomy codes are inclusive of what we call an oophorectomy, which is removal of the ovaries. So they're a plus minus. So providing that the hysterectomy is eligible, we don't get a say over whether their ovaries are taken out or not. But generally, the consultant should be having those discussions with the woman about the pros and cons about removing them. But yeah, from a policy perspective, as long as the hysterectomy is eligible, we don't get a say over the oophorectomy bit because it's plus minus. So they can have that with the hysterectomy if they choose to. And then just a little bit about our Bupa policy here in terms of hysterectomies. As I say, we would expect them to have explored other avenues of treatment first before coming to hysterectomy. So usually like your common treatments that they may have tried to relieve their pain or their bleeding, usually hormonal preparations such as the pill, progesterone tablets or the Mirena coil, which is progesterone, GnRH analogues, so that's things like Zoladex, if you've heard of these, or Prostap injections. They might have had like a previous laparoscopy or the endometrial ablation or potential other surgery. So they might have already had a myomectomy previously, so that can remove fibroids, but then the fibroids might have come back. So the hysterectomy would be then the next curative stage. So yeah, there's lots of different treatment options that they can usually explore before they have hysterectomy. So as I say, generally speaking through policy, that's why we would always ask first and foremost, what previous treatment have you tried? And generally speaking, if they haven't tried any previous treatment, we will often decline the hysterectomy unless there is sort of a good, robust clinical reason why it's not appropriate for them to have other treatments, in which case you will often find that we will request a medical report for myself and Kirsty to review. And then there's just a note there on the bottom about nurse case management, because at the moment we only have one trigger on Swift, which will alert you guys to offer a nurse callback, and that's for the total abdominal hysterectomy. which is the Q0740. So there is a little adjudication message. I think she's screenshotted it on the next slide for you. So it will just ask you for this type of procedure, please advise the customer that a nurse can call them back to offer additional support and information. And if they accept, just make sure their contact number is correct and task it across to us through OGG Nurse Case Management. The P1, P2 or P3 just generally relates to when their procedure is. So if their procedure's in the next few days, just task it across as a P1. If their procedures in the next potential sort of couple of weeks, do a P2, and if it's sort of longer than that ahead, pop it as a P3. So that's just a guide for us so we know the time frame in which we've got to contact them. So as much as that's the only trigger message that we have on there at the moment for that procedure code, please don't feel that you can't offer us to all our members. Which I think Kirsty goes, oh, that's just a little screenshot again of how to send that across to us on Swift. Oh, and then just, yeah, alongside that as well, if you do offer them the nurse case management and they decline it, if you're able to either just set up the task. So in this option here, there is, if they've declined it, there is actually one that says nurse callback decline. And send that to us just so that we're aware that they've declined it, or just pop a note on the task, because what we get is what we call the missed ops every week. So we get a list of all the Q0740s that have been authorised in the previous week. We go through them individually and check if the nurse case management has been offered or not. If it hasn't been offered and there's no note to say that they've declined it, then we are obliged to sort of email the STMs and say, unfortunately, the case management hasn't been offered, and we would then arrange to call that member. So yeah, if you offer it and you decline it, please just try and pop it across to us on the nurse callback decline, or pop a note on so we know it's been offered as well. Just from the tracing sort of point of view, if that's okay. I know you have a lot to do. So we do appreciate that there is a lot to remember on your calls. As I was just mentioning before about medical reports, as I say, it's usually if they haven't tried any previous treatments. First and foremost, try and get through to us. We are there on 59 we're under let me just show you, actually, it's probably easier. So that's us there. So the insurance, clinical service, obs gastro. I don't actually know why we come under gastro, because we're not actually gastro, we're obs and gynae, but that is our 59 link to get through to us on 59. So please come through to us, if you need to discuss anything with us, and we can sort of confirm if we do need a medical report, or we can sort of confirm if it would be eligible or would be a decline. If we are asking for a medical report, the more information that's on it, the better. So generally speaking, symptoms, all investigations that they've had to date and results of those investigations, any diagnosis that it's yielded, any treatment that they've had previously to date, and just a rationale for the hysterectomy, and why they can't have any other treatments, why that is the desired treatments, that we can then review that. The same goes not just for hysterectomies, but generally speaking, when you're requesting any medical report for any gynecology procedures, that's sort of like the general consensus of information that we would want to see on there, just to try and avoid sort of going back and sort of saying, I'm sorry, there's not enough information on this, we need a little bit more. So, the more we can get, the better, to hopefully avoid having to go back and ask for more information. Yes, a quick mention before, as I was saying, with a hysterectomy, the oophorectomy is a plus minus, so we don't get a say. If, however, you do get requests for oophorectomy as a sole procedure, so these are your Q2230 or your Q2231, that's your most common oophorectomy codes. We do at the moment ask for a medical report automatically for all oophorectomy standalone cases. And that's just because we want to know that the clinical evidence is there, because they're really important organs. and they should be preserved where possible. And we just want to also make sure that it's not being performed for any risk reductive or preventive reasons. So Merlin does direct you for any oophorectomy to request a medical report. And again, ideal information that we need, their symptoms, all investigations and results they've had to date. So we often see the oophorectomy request when there's ovarian cyst. So things like if there's any concerning features of the cyst, if it's gone to what we call an MDT multidisciplinary meeting, all that helps to inform the decision for the oophorectomies. So that's those. And then, yeah, I think the next couple of slides, she's just kind of synopsed a bit more about what we do. So yeah, we will always assess any of the medical reports that come in to determine eligibility for obs and gynae. As I say, we're here on the 59 number to answer any of your queries, to help you out with any eligibility queries. We are here to support any of our members, so it's not just for the hysterectomies. So any member that you feel may benefit from speaking with us for any advice or support within the obs and gynae remit, please do offer us. We particularly do a lot of support as well with the ladies that have had miscarriages or stillbirths. But of course, just a note there, you do have, I'm sure you're aware, have the obs and gynae complex team. So that's our advisors that take on the C-sections, miscarriages, ectopic pregnancies and stillbirths and the colposcopy requests. So all those procedures go to our complex team. We're here to provide any teaching that we can. We often refer with the OCMD as well if there's any sort of policy queries that we are sort of a bit, finding a bit difficult to reach a decision with. And as well as getting us on 59, you can email us, you can task us on Swift, and you can drop us a Teams message as well. Obviously, we're constantly trying to keep our processes updated as well, and make Merlin as easy as possible. We are hoping to do some work on Merlin sort of in the coming sort of weeks and months when the platform reopens again for change, just to make it a bit more easier to follow. And yeah, as she's put there, we are basically we're here for you and to support you in any way that we can, and then for you to get us out to our members and to support our members in the best way that we can as well. So I'm very conscious that I just literally read through all that probably without taking a breath. But I will open it up now to you guys, if that's okay, just to see if you have any questions about any of that or just about anything in relation to obs and gynae that I can help you with while I am here today.
No, I don't have any questions, but I'd just like to say thank you for going over that, because I feel like I've got more of an understanding from sort of your perspective of what's involved and what some of the different procedures are. Because obviously we just get people that call in with like procedure codes. We don't really know what they are getting authorised, so it helps to put it in perspective. Even if just a member has a little bit of worry, obviously I know we've got a call back with you, but obviously we can say, well, it's this sort of thing or something. So just some reassurance in general, I guess. So no, thank you for that.
Oh, of course. And we've been, I'm quite happy to send any of you the slideshow if you would like it. Or we do have lots of reading material and resources. So if in your own time you do want to do a bit of reading, a bit more about the procedures, as you say, I think it definitely helps when you're speaking to members if you've got an idea of what the procedure is that they're going to have. To give you that little bit of understanding. So I'd be more than happy to send you any resources. So just let me know if you want me to send any of you anything, for your own sort of reading and reference and knowledge.
Yeah, no, that'd be great. Thank you.
Anybody else got any questions at all? It can literally be anything. Please don't feel silly. I can answer anything within that obs and gynae world, because I know it can be a bit confusing, obs and gynae sometimes, and it can be a bit overwhelming.
Can I just ask, sorry, I work in the customer engagement team, so we do a lot of activity with our corporate clients, specifically on some of our propositions and things like that. Is this service like the nurse case management, something that they can sort of advertise to their employees?
Yeah, absolutely. As I say, we are here to speak to any of our members for anything in relation to obs and gynae. It can be any procedure or just symptom support. So absolutely. We are, we are here as an additional benefit to those members.
Perfect, thank you.
Anything else at all from anybody that you can think of? There's lots of nice quiet, so it sounds like everybody's okay. And I don't think there was
Thank you so much, and for jumping in last minute as well.
Oh, it's
Appreciate that.
absolutely fine. I hope it was useful. I know it was quite a quick sort of snapshot. But as I say, we're always here for you. So drop us a Teams, drop us an email if we can give you any information, if we can give you any help. It can be, honestly, it can be anything. So please do approach us. We're always, always, always happy to speak with you guys.
Thank you. Thank you so
Lovely.
much.
Thank you.
Thank you.
Bye.